So my name is Ari Vanderwalde. I'm a medical oncologist, and I am the Director of Clinical Research at West Cancer Center and Research Institute in Memphis, Tennessee. I'm also the Associate Vice Chancellor for Clinical Trials at the University of Tennessee Health Science Center. I particularly treat melanoma and its associated complications. So COVID-19 has, just as in every specialty, really kind of turned the oncology world on its head. The questions really become the frequency of testing, the frequency of bringing patients into the clinic, the considerations of whether or not to give oral therapy instead of when it can potentially substitute IV therapy, and then more importantly, how to protect patients and how to protect healthcare workers with in-person visits and how to move over to virtual medicine. We've all had to learn a little bit, as if we're learning from scratch, about risks and benefits that we are willing to take with our patients and with ourselves in the COVID-19 crisis. And as we kind of move that risk-benefit analysis a little bit further, toward the conservative side, we really have all had to think a little bit, almost from first principles, about when we need to perform tests, when we need to perform visits, what can go to virtual medicine, and all of the like. My own personal perspective is that this is a very changing situation. And what is true for today might not be true next week or next month. And I think that also we're going to be in this for the long haul. There are certain changes that are occurring that might really kind of last beyond this pandemic, including the role of virtual medicine, telehealth, and potentially risk-benefit assessing a little bit more conservatively when we take care of cancer patients. So in the patients in our clinic, we've changed quite a bit, and this is really in line with what a lot of different practices are doing. I work in a very large community hybrid cancer center, and the place that really has seen the most change is our waiting room. We no longer have patients and staff and faculty milling in the waiting room. Our patients generally wait in their cars until they're called in for their appointments. We are not having patients bring any guests with them into appointments, but it will be just the appointment. We're providing masks whenever we have them to our patients and our healthcare providers who are doing visits. And we're doing everything we can via virtual medicine and telemedicine. And it's actually quite incredible what we've determined, especially with the guidance of the Center for Medicare and Medicaid and the insurance companies that have followed along with them, the amount that can actually be done via telehealth visit, including a rudimentary physical exam, which is something we probably never would have thought of before. Different insurance companies and different jurisdictions have different rules as to what can be done via telehealth. So please don't take what I'm saying as dogma. What is true in our clinic, in our city, in our state might be different where you practice. But it's worth pushing the envelope here to be able to protect patients and staff. So this is a very important question. Our clinic has psychological consultation available in our clinic for those patients who are having the worst types of anxiety and concern. Generally speaking, patients with cancer already have had to deal with quite a bit of anxiety and worry, and the COVID being added on top of that generally tends to worsen already existing or subclinical anxiety that can occur. On the other hand, there are some patients who are very either fatalistic about this or simply have a good attitude because they've had to develop that good attitude as it results in cancer. The most important thing that we can do is acknowledge and validate the patient's concerns. Recognize that we, in cancer, we're very good at, unfortunately, not presenting an overly rosy picture of a patient's circumstances. And I think it's important for us also not to communicate an overly rosy picture of where this pandemic is going. It's also important for us, of course, not to overlay our own non-scientific opinions, especially that which is gleaned from the news media in our conversations with patients, and to offer services whenever they're available, either in our clinic or in the community for patients who do have significant anxiety and or depression related to this. So this is a great question, and I'm going to overlay my bias, which is I'm sure something that many of my peers have noticed as well, which is we have a bit of a system in place where everybody is doing everything kind of on their own. I'm getting probably hundreds of emails a day from various different medical institutions, CME institutions, state society, national society, all of which are sort of erring on the side of more communication rather than less, but it ends up turning into this glut of information that becomes very difficult to process and very difficult to incorporate into my daily practice. So one of the things I think that would be really helpful is if medical education groups, as well as state, local societies, and anybody who's communicating could work together very closely to try to manage the volume of offerings that are given, and to try as much as possible to try to keep everything in as few places as possible. If that's not available to do, I would encourage that that the physicians in our country pick one or two trusted medical education groups that they feel are doing a good job of keeping them up to date, and sort of flagging these as the source of information that they're going to be able to use during this pandemic as to what medical education resources are available. Sure. So one of the ironic things that we have seen so far in the global cancer center care is to modify Samuel Shem's dictum in the House of God, where it says, if you don't check a temperature, you can't find a fever. It's sort of the same thing in cancer, especially in early stage cancer, where if you don't check a mammogram, you can't find a breast cancer. So what we're beginning to see, somewhat ironically, is a decrease in patient volume, not so much yet in medical oncology, but particularly in surgical oncology and radiation oncology. Volumes are going down. And I think that that is as I mentioned before, an ironic situation when we're experiencing a healthcare crisis in this country, and yet so much of the healthcare system, especially the subspecialty systems, are being underutilized. And I think it's something to sort of consider as a way from professional societies, medical education societies, to be able to band together and try to best allocate the medical resources that we have in this country in the most appropriate place that they can. In oncology as well, while if you don't check a mammogram, you can't find a cancer, that only lasts for a certain amount of time. Eventually, cancer will continue to rise. The rates of cancer are not going down, just the detection rates are going down for now. And everything will come roaring back. And I think it's important for practices to anticipate that there's going to be, when this pandemic lifts just a little bit, there's going to be an overwhelming flood of new cancer patients that are going to be coming in, and resourcing appropriately for that, and ensuring that any decreases in staff and faculty that might be necessary during this relatively light time are really not lost forever, and that the practices are able to come back and quickly handle what's expected to be an increase in care is very important as well.